Toxicology and American Society of Addiction Medicine. As webinar partners, we are bringing you this monthly conference on the first Friday of each month from 1 to 2 p.m. Eastern Time. Next slide. For previous FAQs on some of our funded sessions, please visit the Addiction Toxicology Case Conference Webinar Series FAQ page at acmt.net. You'll see a series of facts on very interesting topics that we have discussed in prior sessions. Next slide. I'm Tim Wiegand, the Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center in Rochester, New York. Next slide. We have three distinguished panelists. Dr. Joanne Lace is an attending physician in the Division of Addiction Medicine at Hennepin County Medical Center. Dr. Kelly Ramsey is the Chief of Medical Services for the New York State Office of Addiction Services and Supports in Albany, New York. And Myra Rodriguez Beltran is a guest expert. She's the Director of Medical Services at Hughes Doyle, Rochester, New York. Next slide. Before beginning our case discussion, I want to announce the American College of Medical Toxicology call for abstract submissions for the 2022 annual scientific meeting, which will be held March 11th to 13th in San Antonio, Texas. The abstract submission process is through November 15th, 2021. Please visit the website or email any questions regarding this. Next slide. And we also have the American Society of Addiction Medicine call for abstract submissions. The deadline is September 24th, and this is for their annual conference, March 31st through April 3rd, which is in Florida. And you can visit the website for more information regarding their abstract submission. Next slide. None of our presenters nor myself have any conflicts of interest related to topics to disclose. Next slide. And I'm going to begin with case one, which is when I drink, I black out or do something I regret, and we have a 30-year-old male who has episodic binge drinking to the point of blackouts. He had a recent DWI, or close to DWI, he's still sorting that out, some legal scrapes. And he wants to stop drinking, but not completely. He works in advertising. Alcohol has been an important part of his work and social life, and he feels that if he's not drinking, he's going to be left out. And he's coming to the outpatient treatment program because he wants to do something about the alcohol, but he does not want to stop completely. He doesn't want a medication that'll make him sick. He's heard of medications that help with cravings and is interested in learning whether or not it might help me be able to stop, but I don't want to get sick from it, is what he says. Next slide. The patient has a long history of alcohol use. He started drinking back in junior high. It's really mostly binge drinking. And again, most of the social events that he remembers are associated with alcohol, a lot of family alcohol use and parties in college and high school. During college, he had drank daily for a few months, and he noticed that he had some withdrawal symptoms if he didn't drink, which scared him. He was actually able to stop and limit to social events, which were frequent but not daily. And when he drank, he typically would drink until there was nothing left, into the night, a lot of blackouts, a lot of things he regretted. Next slide. Patient works in advertising, as I mentioned, and several nights a week there's some social events where they will go out with clients, he and some colleagues, and alcohol is a prominent feature at the meals, sometimes during lunch, but usually in the evening. He feels that his peers will ostracize him if he isn't drinking. Despite discussion on ways to counteract this, and working on your health, trying to cut it out for a little bit, just don't want to drink. He says it won't work, I'll be left out. He's very persistent, and he feels it'll leave him out of opportunities with clients and to move up in his business. He has a history of borderline hypertension. He had intermittent cannabis use, still occasional, 1 to 2 times monthly, but not regular. He had tried cocaine in college, but didn't like the edgy effects. He has reflux, gastroesophageal reflux disease. He picks up over-the-counter medication for that. He lives alone in a city, a large metropolitan area. Family is not in the city, they're outside of the area. They don't really understand the alcohol use disorder, the problems with alcohol, so he doesn't really think of them as supportive, but he's not really talked to them about it. He's a non-smoker, he has a history of vaping, and again, he binges to the end. Lots of blackouts, near DWIs, and this something recent that may or may not be a DWI, and then things they shouldn't be doing. Next slide. My question to the panelists is, what is your approach to this patient? How do you respond during your first encounter? I'll start with Dr. Ramsey.
Thanks, Tim. So I think the patient has made very clear in the presentation what his goals of care are. And in surveys, about 60% of patients surveyed with alcohol use disorder don't want complete abstinence. Some want abstinence at some points in their life, perhaps around a particular event. And some patients really just want to decrease the harm that they're having in their lives due to their alcohol use. So I think that it's important to listen to what the patient is trying to accomplish here and then try to come up with a treatment plan that works with him and that he's willing to do. Because if we come up with a treatment plan that he doesn't subscribe to, then obviously he's not going to follow through on it.
Yeah, those are good comments. I think he would have headed for the door had this been, well, we really need you to stop drinking because bad stuff will happen. So Dr. Lace, do you have any other thoughts or comments?
I agree. I think a lot of people, when you give the traditional, like there's outpatient treatment, there's inpatient treatment, that isn't necessarily in line with the availability they have in their life to engage in that, nor in line with their goals.
Myra, do you have any other additional comments?
Yeah, I agree with the comments. I think that I would still talk to him about the options of treatment, what's available, and then work with him on his goals and what works for him specifically.
Right. And some of the impacts and regulations with COVID are actually working in the favor for him. He doesn't want to come to a group 3 times a week, and telemedicine, telehealth encounters are ideal, and really flexibility and patient-tailored approach is really going to work, I think, better, and certainly change some of the planning depending on his goals and stage of change. Let's move to the next slide. So my question to the panelists is, has anyone used as-needed naltrexone? Because that really came up in the consideration. We actually reviewed the different options for alcohol use disorder and explained the mechanism, and he definitely didn't want anything that made him sick. I think he had read about the disulfiram, but he was intrigued by naltrexone and had heard of an individual using it to curb their drinking. So I'm wondering, does anyone have any experiences on an as-needed basis before a social event, and if so, how effective is it? And start again with Dr. Ramsey.
So I have used a PRN naltrexone, PRN PO naltrexone with some patients, as well as PO disulfiram, PRN with patients. And interestingly, patients who I prescribed acamprosate to have had a really hard time adhering to the TID dosing. So instead are only taking it once a day, just a single dose of 3 doses daily, and have done well with that. I was doing a literature search before today just to see what I could find in the literature on PRN naltrexone. I actually didn't find very much on PRN naltrexone, but I did find a trial on PRN nalmefene in Europe, which did show, again, similar to sort of naltrexone clinical trials. It showed decreased number of binge drinking days and decreased number of drinks per binge. So very, very similar to naltrexone data in general. And again, that would be in alignment with what he has stated as his goals for treatment. So I think that that could be a very workable strategy for him.
Yeah, that's great. And there is, my review of the literature was the same. It's not a lot out there. I have heard anecdotally from others, and I've used it in patients, comment a little bit about how effective it is, but your comments are in line with my experience as well. Any other comments, Dr. Lace?
I haven't used PRN per se. However, I generally do prescribe from the inpatient setting, and we have the option of giving the injectable version of naltrexone. However, I think what happens with that is that the follow-up plan, they get a month of it, and then they don't really start on the pills or continue the injections after that. but they do mention, they're like, I think it did help when I had it available. So I think that there is some merit to if they are able to remember to take it when they're wanting to need it. If they don't have a social situation that allows them to be intermittent like that, it's probably better to have a regularly scheduled medication.
Yeah, those are good comments and the pros and cons of both. I think the tablet and intermittent dosing, one may forget, although he's highly motivated because he has specific episodes and is a non-daily drinker. He did not want to get the injectable, although that was discussed. I think just like alcohol used to sort of starting medications, on demand rather than waiting down the line when somebody's established in treatments, and delaying initiation can really lead to problems, relapse, gaps in care, continuity. So your points are well taken. We have a comment in the chat that is, will Vivitrol or IM naltrexone be an option for this patient? And that, again, was addressed by Dr. Lace. And another comment, in my opinion, PRN should be considered for drugs which is used in emergency situation before to receive medical help. And that probably wouldn't necessarily be used in emergency situation here, but to try and preempt the escalation of drinking. Certainly emergency if someone's at risk of an opioid overdose and using stimulants in an area of where they're adulterated with fentanyl potentially. Let's go to the next slide.
Dr. Regan, there's
So
a question also on the chat.
Okay.
The question is, are there other things that we can do on a community public health basis that may help normalizing not using alcohol as part of business events? Or are there no other societal will? There are alcohol-free sections in the NFL stadiums. I loved the time I attended ASAM, and it was a substance-free medical meeting.
Dr. Ramsey, do you want to comment on that?
I mean, that's a whole other ball of wax, really. I mean, I agree with you. I think that there should be an option for people who want to be in an environment that doesn't encourage or make people feel excluded if they don't want to engage in imbibing alcohol. But again, within the context of this case scenario, that's the pretext of it. So that's all I have to say. I agree with your point overall, yes.
Thank you. I've got the Q&A up, I think, instead of the chat. I was just trying to open the chat so I can see that. So, well, this patient's given a prescription for 50 milligrams a day naltrexone, just at 30, one to take in the afternoon before the social event, not immediately before, but several hours. He doesn't want to get the extended release shot, just wants to take it. And he notices that first time he takes it, he notices he's able to drink 3 to 4 beers and put it down and stop and then have conversation like the rest of the group. He wasn't blacking out and doing things. He says, it was like magic. I could set them down and didn't end up in the closet. And so it was a good response. At a follow-up visit several weeks later, he maintains that the PRN naltrexone has helped him dramatically. He is offered additional supports, including working with a counselor, and prefers to have just interactions with the addiction provider. And we're having ongoing meetings to discuss where he's at and how the naltrexone is working, referral to primary care provider, motivational interviewing techniques used at each meeting visit, but he's really set in the reducing his harm of drinking, but still feels that it's an important part of his social and professional life.
Just one thing I would add, Tim, is for him, if you don't mind, for him, because again, AA really supports people being abstinent, so they may not support his goals here. So another alternative for him would be smart recovery, which again is more patient defined or individual defined goals. So he may find that that's a more supportive environment for him.
That's a great point. There's definitely different resources. and including apps and social media support, ways to connect in a lot of different mediums, and again, AA, smart recovery, different options. I agree that you may not fit in with the traditional AA model. Next slide. Before I get to the case 1B, which is just a little bit different, any other final thoughts on the use of naltrexone in this case? It's ongoing. We'll see where we're at in a couple of months, and if he progresses or if it loses efficacy. Has anyone, and when you've used this, Dr. Ramsey, have you seen it lose its effect as people have tried it as needed?
I personally haven't seen that, so no. But there is another question in the Q&A, so I would love to take a first stab at that. What would you use for his AUD if he also had concomitant OUD? So assuming that I was treating his OUD with buprenorphine, which was most commonly, obviously, what I was treating patients within an outpatient setting, but they had concomitant AUD, I have found acamprosate, again, not necessarily up to TID dosing. So most of my patients were just not able to do TID dosing. So even if they were able to take 1 or 2 doses a day, I did notice, again, this is anecdotal, but anecdotal improvement. And I would say that it was supported by their alcohol levels, so that I would check for ETS and ETG to monitor them. And it was supported that using it as they were using it, even if it wasn't as prescribed, seemed to help them with their alcohol consumption.
That's a great comment. I've not thought about recommending it, taking it all at once. I've found that taking the 2 pills 3 times a day is their biggest barrier to acamprosate as well. But we'll have to look at patients taking it just simply all at once, because that certainly would improve compliance. I've recommended individuals carry around a keychain pill bottle to help remind them to take the 2 in the middle of the day, but I think all at once would be reasonable.
And just to be clear, they weren't taking it all at once. They were actually not taking it all. So they were taking only 1/3 to 2/3 of the recommended dosing and still doing well.
Interesting. Dr. Lace, do you have other comments?
As far as the PRN of acamprosate and the PRN of naltrexone, I think that there was a comment in the chat saying that there's a lot more that use it PRN than let on. So I would really guess that this is the way that a lot of patients are using it.
Yeah, I find
I
that
agree. I think
for patients that that I prescribe it on a daily basis, they're mostly taking it as needed and not necessarily on a daily basis. So they're doing that on their own.
Yeah, I agree. I think that finding out how people are taking it's important, and encouraging to take it, in particular if they're episodic drinkers, and that's okay. They're not, if one gets off track, and not stop completely.
The other thing that I make sure that I mention to them, because a lot of patients think that, okay, if I am planning on drinking today, I shouldn't take my medicine. I make sure to let them know it's okay. You should take your medication even if you're planning to drink that day.
A good point to remind them. I agree. People stop taking it because they feel that the alcohol and the naltrexone will be a problem, but reminding them that that's going to help them curb their craving as they drink. I have had patients report that they've had a response in the beginning. Usually this is with this intramuscular naltrexone, but over a course of a couple months, or even at the end of the month, the effects wane, and sometimes supplement oral naltrexone. But I've had some patients describe that it's just what they had initially isn't something that has been sustained, and I decided to come off of it because it isn't working for them. But the PRN naltrexone, I think, is a tool in our toolbox that we should remember. Let's move on to the second case. This is actually case 1B. We have a 36-year-old gentleman with severe alcohol use disorder requiring hospital detox twice. He's staying with his parents after a second recent ICU stay for severe withdrawal. He was in an inpatient program for 4 weeks after the second discharge, and then discharged home to follow up with an intensive outpatient with mental health counseling. Due to alcoholic hepatitis, naltrexone was not started in patients and was waited for a follow-up visit for liver function test. And he's been home attending AA meetings. He's been linked with a peer, doing several different types of activity, trying to exercise, to try and stay sober. But he'd relapsed for 3 days. His parents were monitoring his credit cards and noticed that he'd been at some bars and was spending some pretty significant amounts. And they'd confronted him and just tried to keep him at home. He's still attending some AA as a peer support, and he's just trying to hang on. He reaches out asking about disulfiram and whether that could be something that could help him. Next slide. So often, my question just to the panel is, how often are you using disulfiram in practice? And is this patient a candidate? He had life-threatening withdrawal, VTs, nearly died twice in the last 6 months. He had been put on oral naltrexone after the first hospitalization, but before a scheduled appointment to get the injectable, he had relapsed and ended up back in the hospital. He was also placed on a camprosate and valproic acid briefly after the first hospitalization, and some medications for depression and mood disorder. But he's at home and trying to do this via telemedicine and coordinate. Can we safely start disulfiram? So Dr. Ramsey, again, I'll start with you.
So I've had really actually little clinical experience with disulfiram. Most patients in my experience have not been interested in it. So I only have an N of 2. And in a patient like this, you do have to be cautious with people who have active hepatitis or just liver disease. It's not contraindicated, but it's use caution. So that's my one caveat about using it with someone like this. But again, my clinical practices, I had a patient who had been on it for years. It was actually prescribed by his psychiatrist, and he was also on buprenorphine and doing well on it, and he wanted to stay on it. I had another patient who was also on buprenorphine, and his alcohol really became a problem, his alcohol use. So I started him on a camprosate, which he did well on. He was also cirrhotic. And then he was going to spend holidays with his family, and his family tended to be a trigger for him to resume use of alcohol especially around holidays. And so he asked me for disulfiram to use, again, sort of as a PRN on that trip. And that worked well for him. There's another patient that was in clinical practice, not my own patient, but a patient of one of my nurse practitioners whose patient had very, very severe alcohol use disorder. He was getting injectable naltrexone as well as PO naltrexone on top, and actually was looking for extended release disulfiram, which I've never used in clinical practice, and was not able to access it for this patient. So I'd be interested if any of the other panelists have had any experience with that, with extended release disulfiram.
I have not had any experience with extended release disulfiram. I have had nearly identical situations this past holiday season. Same type of patient requested disulfiram. Have one currently doing the same thing for a period of time, even accessing pharmacies that had stock of disulfiram. There's a shortage, I believe, and it's just recent that at least in our area, I've been able to find it again where it's not on shortage. But I've not seen extended release disulfiram. Dr. Lace, with you.
I haven't seen extended release disulfiram. However, at our methadone program, we actually use disulfiram as an adjunct for people with concomitant alcohol use disorder. And it's nice in that scenario because they're there, a lot of them are face dosing 5 or 6 times a week. So it's that supervised setting that's ideal for disulfiram. I think that with the alcohol hepatitis, I see the initial reluctance to start naltrexone. However, I would argue that if they really have, chronic liver dysfunction, the liver toxicity with disulfiram, even though it's idiopathic and not necessarily a dose dependent thing, that actually has gone on to liver failure. So if somebody has a compromised liver that would not be able to take any additional hits, I feel that disulfiram is a little bit more of a risk than naltrexone would be.
Yeah, that's a good comment. Now, this patient had decompensation in the hospital setting, but improved, so he's not an end-stage cirrhotic. And each time he resumes drinking, it's rapidly led to life-threatening withdrawal, including episodes of pancreatitis, one hemorrhagic, really severe DTs. I have also heard of adding the disulfiram into the methadone and the opiate treatment program. Our program, Dr. Bishevitz, is not on. I know that they have done that for some of the patients. We're speaking with a patient yesterday that wasn't aware that that could be done, and was going to try and coordinate with his opiate treatment program medical director, or at least suggest, because I don't believe the program that he'd attended had routinely done that as part of the practice, but one in town does. And so if he's patient has to be motivated to take the disulfiram. My experience with disulfiram is if the patient's asking about it, is motivated, that's when typically they are candidates, or if they want to build trust, are looking to try and have a partner or parents brought back into their life. And again, they're fully aware that drinking and even some sensitivity to products containing alcohol may occur, but that it can be effective. Watch me take this pill, that I'll get sick. I have had situations where someone has emptied the disulfiram out and replaced it with acetaminophen. So I will let the partners know if that's the case, just to know what the disulfiram tablets look like, pill ID. I think looking at Dr. Ramsey's comment about biomarkers for alcohol consumption for all of the patients are very useful to drive discussion. Are they lower self-reports? Certainly important as well, but can really help guide efficacy. Are we effective with our treatments like ethylglucuronide, ethyl sulfate at intermittent visits? Dr. Lace, you'd commented. Myra, any other additional comments?
No additional comment. My experience is pretty similar. Typically, the highly motivated, the one that's asking for it is the one that's going to take it. When it's me recommending it, they may say yes, but then I find out they never filled the script, most likely. There's a couple comments in the chat in regards to the disulfiram in the OTPs. The question is, do patients bring in their own disulfiram? Does the DEA allow you to store the patient's disulfiram at the OTP?
Dr. Lace had commented, disulfiram is given as a separate tablet from the liquid methadone. It is administered as part of the medication administration program at the OTP, so dose there. I will double check, but I thought from what Dr. Bishevitz had told me, they were actually giving it dissolved in with the liquid, but it would make sense that it could be given concomitantly. It's not a controlled substance, easily stored. Let's
Tim,
move on to the next slide. Go ahead, Kelly.
Do you mind if I just add one other comment about the alcohol levels? So again, I use toxicology merely just as a data point, and it is just for conversation with patients. So when I used to only check an alcohol level, which obviously it was easy for people to have a negative alcohol level when they came in to see me because they knew they were coming in to see me. But when I started doing ETG and ETS levels, it led to far more meaningful conversation and far more honest dialogue around how someone was doing, if they were doing well or not well with respect to their alcohol use. So it let us actually have a much more meaningful conversation.
Right, I agree. I hope can support progress with lower levels, as well as guide treatment too if levels are really high, more meaningful than just the spot alcohol checks. Next slide. So he's motivated. Before starting this, I really wanted to get a handle on whether he was actually able to stop drinking, and with both discussion with the parents and the individual, monitored for 24 hours, is able to stay home and I thought he was going to develop withdrawal symptoms. He had maybe some mild symptoms, that he had some clonidine, that he was able to take some anxiety and the edge off. And he was taking valproic acid as well, 500 twice a day, so that may have helped from progressing into a more significant withdrawal. But we started disulfiram 24 hours after the last, after symptoms, mild symptoms subsided, and probably 48 hours after his last drink. 500 milligrams for 14 days, and then 250 milligrams a day, and he was able to tolerate it and avoid alcohol. Parents noted that he's going to meetings, not spending at the bars, and they notice that he's not drinking. It's very obvious when he's drinking during the day. He's staying with them. He does have follow-up to get naltrexone and acamprosate initiated. He wants to continue the disulfiram. The case is ongoing, but the disulfiram appears to have helped him stabilize at least, and to have that reminder that if he drinks, he will get very sick. And he's not at least tried to test it, as far as I'm aware. And so he's in an intensive outpatient, getting mental health and using medications that seem to be effective at this point. Any additional pearls regarding use of disulfiram?
The only thing, and I would just reinforce considering it for PRN use, and also that there's flexibility in dosing as well. So if a standard dose, maintenance dose, isn't working well, there is flexibility to increase that dose as needed.
And I would add that there is
Sure.
additional toxicology related to the use of disulfiram above what you would see with naltrexone and acamprosate, due to the CYP enzymes that are used to metabolize it, the potential peripheral neuropathy, or the idiopathic hepatitis with disulfiram. So a little bit more side effects that you have to educate the patient about.
That's a great comment. The monitoring the neuropathy can develop, and monitoring for side effects is important with any medication. There's a couple of comments in the chat. Again, one is regarding the storage of the disulfiram for an OTP. I'm curious how others are making this work. Eve Klein mentions DAA wouldn't let us store patients' disulfiram or any other meds, regardless of whether scheduled. We haven't been able to motivate patients to bring it on in themselves. So is any, Dr. Lace, comments on that?
It is not a prescription that's given to them. It's administered much the same way methadone is, where it's an administration and then there's takeout doses. So it's not a prescription that's filled at a pharmacy. However, we do separately have a medication compliance program that we did work with the state, and I believe the DEA on for administering necessary patient medications, but that's a separate part of our OTP. That's, I think, something that you have to work with a few different regulatory agencies to do.
And especially if an OTP has primary care or just full spectrum medicine at the OTP, then often there are a lot more options for, partial DOT or full DOT with all meds. So yeah, I would say check again with your SOTA.
And then there's a comment: if any of the panelists treated patients who wish to use disulfiram on a PRN basis, any tips? And yes, we talked about that at the beginning. By both myself and Dr. Ramsey, and I think the other panelists also have experience, in particular around the holidays for patients, or just simply if they're concerned about an upcoming event. I had a recent wedding. A gentleman was going to a wedding where he felt there'd be a lot of alcohol consumption, so I gave him a prescription, educated him about the disulfiram, and he took the tablet before the wedding and have some additional. Didn't drink at the wedding, worked well. So I think the key is educating the patient also, that they may have sensitivities to the alcohol in mouthwash or any other of the products that contain ethanol, cologne. Then there is a comment: agreed, PRN is great, especially if the patient is contemplating relapse, for example, a wedding. The risk of disulfiram impacting the liver is likely less than the risk of their drinking. I also like it for cocaine, alcohol co-occurring use disorder, and that's a great comment. I think disulfiram off-label for cocaine use disorder inhibits some enzyme dopamine beta hydroxylase, which actually then leads to increased levels of dopamine, thought to be less cue-induced craving when one is exposed to cocaine, or less reward. So it doesn't work the same in terms of causing a disulfiram reaction for cocaine, but there is less cue-induced craving, and I've had effect in cocaine use disorder, both with and without use of alcohol for patients. Any other comments regarding that, Dr. Ramsey?
I didn't have any comments regarding that. I don't know if anyone else does, but there are several questions in the Q&A box. Do you want me to read those?
If they're pertinent that we haven't addressed, go ahead.
So one is just asking if people use all three drugs concomitantly. I have used disulfiram, camprosate, and naltrexone all concomitantly. So the next one is, please discuss guidelines you use with regard to liver risks and disulfiram. Specifically, what LFT results do you use as a cutoff level above which you do not use it? And then in addition to that, by the same questioner, is how often do you check LFTs in a person taking disulfiram? So I'll start with, oh, sorry, go ahead.
No, go ahead, Dr. Ramsey.
So I was going to say, again, I have very, very limited clinical experience with disulfiram. So as an N of 2, so one was in a person who had a healthy liver, and the other person was a person who had cirrhosis, who I just used a PRN in. And the vast majority of my patients had comorbidities that required blood work approximately every 3 months, depending on their comorbidity. So most of my patients got blood work every 3 months.
Dr. Lace?
I usually would get baseline LFTs just to assess where their liver's at. And then because it's an idiopathic hepatitis, it's hard to know exactly what the risks are, because it's not necessarily increasing doses will cause a hepatitis. So monitoring LFTs makes a little bit less sense in this scenario. Yeah. I would say monitoring for hepatitis, signs of hepatitis.
I think really there's guidelines and in terms of checking LFTs and where potentially naltrexone, disulfiram may or may not be indicated, but weighing the risk and benefits when somebody has the exposure to alcohol and has recurrent alcoholic hepatitis, if a medication is able to be started as their liver function is improving, certainly can be life-saving. So I've been fluid with some of the guidelines in some patients where I felt like their drinking was going to kill them, and we had an opportunity to stabilize. Some good questions and good comments. All right, next slide. All right, this is the second case, detoxing at home with support. Next slide. This is a 38-year-old with a history of alcohol use disorder and 2 recent medically supervised detox visits. He's interested in ambulatory withdrawal management. Is a history of 1 bottle of vodka, 750 milliliter bottle daily. Although he says he's recently cut down to just beers, about 7 to 8 with a higher alcohol concentration, so it's 8 or 9%, just to maintain. He tried ambulatory withdrawal with phenobarbital in the past, although that was associated with a partial day hospitalization visit and 2 take-home doses at night. But basically, the patient spent 8 hours a day at a outpatient treatment program with a counselor peer kind of structured setting. He's interested in doing this again. That model is not available with COVID, however, the partial hospitalization. He has no other substance use. Medications include gabapentin, 600 milligrams 3 times a day, sertraline, 100 milligrams a day, trazodone, 100 milligrams at night, and Keppra, levetiracetam. He's had 1 seizure in the past. Probably was alcohol withdrawal related, but he's been continued on Keppra. Next slide. Describe the ambulatory withdrawal management, how to screen patients for appropriateness, protocols, what your risk-benefit threshold is, and what do you want to know? What more do you want to know about this patient in particular? Start with Dr. Ramsey.
So I don't have a ton of experience with ambulatory withdrawal management for alcohol. I've only done it maybe a couple times in patients that I knew really well. So I think it's really important to know what their comorbidities are, what their history of alcohol withdrawal is, complications such as seizures, DT. Was his one seizure in his history due to alcohol withdrawal, or was it for some other reason? And I think it's really important to know what kind of support that person has. And if you're going to be doing an ambulatory detox, again, this is somebody that you want to be able to touch base with daily as needed, and is somebody who is going to see you weekly. And so if it doesn't seem like the person is going to be able to do that, then I would be very hesitant to treat them in an ambulatory setting.
Yeah, those are great comments. Dr. Lays?
I haven't had the opportunity to do ambulatory withdrawal management, but I agree it would need to be, the setup would need to be with a program that offered some sort of daily touch point. I think that using phenobarbital or benzodiazepines as an ambulatory management, that I would be harder pressed to do that. But definitely would be open if they don't have a seizure history, if they don't have the history of the severe alcohol withdrawal, to consider other agents such as gabapentin or valproic acid.
Good comments. Myra, you have some comments. What more do you want to know about this patient?
We've used the PAS score, the predictive alcohol withdrawal scale, severity scale, and it helps understand based on history. There's some questions that you ask based on previous history of alcohol withdrawal for the patient and other key points. It comes up with a number of how severe or how likely is it for this patient to develop severe alcohol withdrawal. And if it's in the mild, then mild to moderate, then you can be a little bit, it gives you a little bit more comfort that probably ambulatory withdrawal management would be okay with the appropriate supports at home.
Yeah, those are great comments, and we can get into the pause in just a minute. This gentleman has some risks that I'm very concerned about. The two recent medically supervised detox episodes of return to drinking. He's taking a medication that induces tolerance to gabapentin, which is a medication that I would be my go-to for ambulatory detox. While I love phenobarbital for alcohol withdrawal in the ED and in the hospital inpatient setting, regardless of whether ICU, ED, hospital floor, I'm hesitant to give it to a patient outside of that partial hospitalization context where we can monitor them if they return to drinking, was drinking heavily with phenobarbital in the outpatient setting. I would be concerned, although I do know some providers that do use that as a protocol. I'm more comfortable with a combination of gabapentin and valproic acid and sympatholytic like clonidine. And I agree with Dr. Ramsey. This is, I stress the need upfront to have daily contact. With COVID, it's really been telemedicine, doing a lot more of this with telemedicine and out of necessity. And then I schedule usually 1 or 2 visits where the patient can come in so we can check biomarkers and just do a visual face-to-face to see how they're doing, and have that brief contact. And ideally, they have someone that's able to monitor their medications, to watch how they're doing. But I have done it for individuals that I felt were motivated and didn't have anyone at home. And then, as we'll see as this case discusses, I have had different gradations of tolerance and also prescription of what I thought risk-benefit of might help cut down some of the symptoms, but really lead the patient to understand that this isn't going to work at home. You're going to need to go into a detox rather than be like, nope, I'm not going to prescribe anything, and I need you to get into a detox and do this. We'll talk a little bit more about that. So let's move to the next slide. The pause by Dr. Jose Maldonado, the prediction of alcohol withdrawal severity scale, is a screen. It's used for hospitalized patients for complicated alcohol withdrawal to predict the risk for complicated alcohol withdrawal. It's for patients 18 years or older, the general floor, with or without history of alcohol use disorder. The first threshold criteria is, has a patient consumed any amount of alcohol within the last 30 days, or patient had a positive blood alcohol level on admission. If no, then your threshold criteria aren't met. You're not going to have a risk of severe alcohol withdrawal. Next slide. If that threshold criteria is met, then there's a series of questions, each one scoring 1. Have you recently intoxicated or drunk within the last 30 days? Yes. Have you experienced previous episodes of alcohol withdrawal? Have you experienced withdrawal seizures? Have you experienced delirium tremens? Have you undergone alcohol rehabilitation treatment, inpatient, outpatient, or attended any of the supportive programs? Any blackouts? Combined alcohol with other downers, benzodiazepines, barbiturates that add the gabapentinoids in the last 90 days? Have you combined alcohol with any other substance during the last 90 days? And then the clinical evidence is that there positive blood alcohol level on presentation or increased autonomic activity, tremor, heart rate, sweating, agitation, nausea. And if there is a score of 4 or above, suggests high risk for complicated alcohol withdrawal syndrome. And then that prophylaxis and treatment may be indicated. It's just not absolutely necessarily, but may be indicated. And these patients are either stratified high risk, and you can face protocol decisions about this. Next slide. So patients' detox episodes were for 6 days each, about 4 weeks prior. 5 weeks prior to that, he was in the detox, and it was managed with diazepam and clonidine each for about 4 days. He was given a prescription for naltrexone, but he didn't take it, declined follow-up with an outpatient treatment program after each visit, which he's calling now based on the advertisement of ambulatory withdrawal support for appropriate patients. He lives alone, though his family in the area. He's working intermittently for IT, information technology from home. Other than tobacco, no other substance use currently. Recent primary care physician visit with normal labs, including LFTs, no recent hospitalizations, no prior psychiatric hospitalizations. He's not had episodes of suicidality or suicide attempts, self-harm attempts. Next slide. Patient is counseled about risks of ambulatory withdrawal management and asked to come on site for an in-person visit. Risks that it doesn't work, you progress, have a seizure. If this is done, we need to have parents, family members checking in, and as panelists have mentioned, regular contact. And to start, they prescribe some stabilizing medications, valproic acid 500 milligrams twice a day, naltrexone 50 milligrams a day, and clonidine 0.1 to 4 times a day, and advised to continue the gabapentin. And after coming in, kind of describe the protocol. If you come in, you're going to take 2 of the 600 milligrams in the morning if you've been able to avoid alcohol from the night prior. And then you continue with 600 milligrams 4 times a day, and a 5th one extra at night with the valproic acid, clonidine, naltrexone. And if he shows up and this is working, we can proceed. If not, then we're going to not continue this, and you're going to need to have withdrawal management and appropriate level of care. Scheduled daily check-ins, via telemedicine, and then a second on-site visit. And told that he's drinking on the above or has withdrawal symptoms. Despite that, then we'll have to have some more support monitoring and support that isn't in that the ambulatory level just isn't going to be safe for him to continue. Any comments on this protocol or thoughts, or would anyone not have, any panelists not have proceeded in this way? Dr. Ramsey?
Did we find out about that seizure in the past?
A seizure is remote and was after drinking, poorly defined. He was left on Keppra based on a neurology consult. So from the discussion, it seemed that it was related to alcohol and cessation, and there's no other seizures. He was just simply left on the Keppra.
So probably with that particular history, I probably would not have done ambulatory detox for him. And just to put it in context, because obviously everyone on this panel has a different practice setting. My previous practice setting was in an FQHC. So again, outpatient, no hospital support, no on-call, but on-call within primary care, and primary care not used to treating either opioid or alcohol withdrawal, even though you would think it's in the context of primary care. But it wasn't. So probably with even that just sort of fuzzy seizure history, probably not somebody I would have treated in the outpatient FQHC setting.
Yeah, those are great comments. I think in particular, the mention of some, not having someone on call, having on call if there's a concern. Certainly during COVID, there was, if we had some parts of New York State that just simply didn't have access to detox beds or even inpatient beds, in particular early on in downstates. And depending on what state one lives in, certain levels of insurance don't cover the detox setting. And so ambulatory detox is more common. I know in California, I've heard Dr. Hurley, who's on the ASAM, he's ASAM president-elect, present on ambulatory alcohol withdrawal management, and this protocol is essentially identical to what I use, maybe some slight variations. But risk depending on the pandemic and other things may be a fluid line where you draw the line. I was hesitant for this patient and thought that we probably are not going to be successful with this, but I wanted to at least to bring him in, go over the protocol, and kind of have a face-to-face and see if actually had avoided alcohol, and then so we could proceed. Next slide. Patient misses the in-person visit and follow-up call. He answers a third call and is connected with the counselor in between, and so the ambulatory withdrawal management is put on hold, or not undergone, not put on hold because of the he's drinking and not able to follow the protocol. Some of that may have been lack of support at home and just the severity of his alcohol use disorder. They're trying to get into a detox unit to treat withdrawal. He maintains he's only drinking beer, a little bit less, although during the phone calls, he sounds intoxicated and disinhibited. So I suspect that there's more than just a few beers a day. Next slide. Want to provide just a resource. The ASAM Clinical Practice Guideline on Alcohol Withdrawal Management includes guidance at all levels of care, from the ambulatory setting to the ICU, and a great overview of different medications and treatment of comorbidities and different protocol. Let me look to see if there's any comments or girls in the chat. Only drinking beer, I've heard that often. Thank you for the details. How long was he continuing on valproic acid for stabilization? Keppra continued as well. The Keppra we're trying to sort out because, again, I think that that was just left in place. The valproic acid I like to use adjunctively for up to 2 weeks, even a little bit longer, is a part of the initial treatments. There's several different mechanisms, but it is indirectly GABAergic. It raises the levels of GABA. So it's another way of treating the actual withdrawal. And then I find that it helps with the kind of some of the subtle protracted symptoms, the mood stability, insomnia, anxiety. This chronic alcohol use leads to downregulation of the GABA receptor, distortion of the signaling, efficacy of the benzodiazepines decreased. So valproic acid and the gabapentinoids, I think, are good medications when started early in particular. I've seen patients with fairly severe alcohol use disorder, and we, in a former webinar, discussed the mixed alcohol sedative use disorder that was managed in the ambulatory setting during COVID very successfully with aggressive gabapentin and valproic acid initiated early on. So I don't know if others have different practice styles, but mine would continue for 2 weeks for the valproic acid and reassess. Any other comments?
It looks like there are a few questions in the Q&A portion.
Go ahead.
How many of the protocols are actually evidence-based?
Well, they're quite well. You'd have to look specifically at the protocols. The ambulatory withdrawal management is being increasingly studied. And references. There's references that I don't have the guideline open, but I can certainly add some references and provide the guideline, or just simply access it at the link which is provided here. These slides will be available. There's several studies involving phenobarbital in a variety of settings that show that it's a very effective agent, benzodiazepines, evidence-based treatment. So you'd have to look specifically at the protocol and which evidence, but there's emerging evidence on the use of the gabapentinoids. Gabapentin in particular is as effective as lorazepam in several studies, and can also be continued potentially for craving after the treatment of withdrawal if patients have alcohol use disorder alone at doses of, I believe, 900 milligrams 3 times a day. There's a study that showed the number needed to treat with 7 for individuals to have 12 weeks of abstinence and other markers of improvements when it's used for craving as well. So we didn't talk about gabapentin as a craving medication, but in some of the ambulatory withdrawal management protocols, I'll continue the gabapentin as well at a lower dose for craving and often combine that with naltrexone. So there's some good comments, certainly looking at the evidence basis for protocols and what one is doing. I think this is the last slide. So any other comments from the panelists? Dr. Ramsey, any final comments?
So I would just say that plug the guideline as well. The ASAM guideline is excellent on alcohol withdrawal management. So if you haven't looked at it, I really would recommend looking at it. And also every year, and particularly the last 2 years at the virtual ASAM meeting, there were excellent talks on ambulatory withdrawal, going through a variety of different protocols and how to assess patients safely to see if they're good candidates for it. So I would recommend that if you did go to those conferences, that you go back and look at those talks, or try to listen to any of the talks that are archived on the ASAM website.
Should be an archive one from Dr. Hurley. Seen him present on that as well. So good points. Dr. Lace, any final comments?
Just a quick comment on gabapentin. I think that it is a useful tool. I think that it's also important to be aware of people who misuse the gabapentin and to set a time limit or to really monitor what you're doing with the gabapentin.
Yeah, that's a great comment. If there's any component of opioid use disorder, I stay away from it. It can be just a very substantial problem used as a potentiator, and it seems to be the population is much higher affinity. I have had patients with alcohol use disorder also decide that the gabapentin was euphoric and or have that reaction, not decide, but have that reaction and overtake as well, but to much less extent than patients with opioid disorder or other substance use disorder. So I generally would only use it in a patient that had alcohol or alcohol sedative use disorder and then set guidelines. So great comments. Myra, any final comments?
Just a final comment on how COVID affected alcohol use in our population and how it really impacted the way that we were delivering services. And our program in particular was forced to look at the option of ambulatory withdrawal management for alcohol because our local detoxes were full and up to capacity, and alcohol use continued to increase with the pandemic. So it has been an additional service that we're providing, and it's made an impact.
Yeah, increasingly people are very pleased and safe and effective when done appropriately. You need the resources and experience with it, but the mentorship and guidance is out there. Okay, no other further comments? The final thought is based on a Lakota saying, "Today is a good day to die." And that is from Tasunko Whitco's Crazy Horse, a holy man in Lakota who often rode into battle unafraid of bullets. His words, "Today is a good day to die," are immortalized among the Lakota. They represent the philosophy that life is a circle, just as stars, the moon, and the sun are circles. We're born, we live, we die. They also represent the philosophy of living one's best and not fearing death. That takes away from the present. Remember, cowards die many times before their death. The valiant tasted death but once. This is just from a recent Adirondacks trip myself, my son Eli, Charlie, and that was reading Jim Harrison's A Good Day to Die, which is a great book. If anyone has not read Jim Harrison, he's a great author. Fiction, poetry, and essay, a gourmand, an outdoorsman, and a lover of life. So today is a good day to die. Last slide. Thank you for joining today, despite Labor Day weekend. I know everyone's busy. Our next conference is on October 1st, so mark your calendars. If you have thoughts for topics or have expertise and are interested in being a panelist, please email me. And as always, I welcome your comments and feedback. And I want to thank Dr. Ramsey, Dr. Lace, and Myra for joining us today as the expert panelists. And again, we had some great audience participation and discussion. So thank you as well for your comments. Happy Labor Day and stay well.
Thank you.
Thanks, everyone.
Thank you. Bye-bye.